Greetings, Nursing 203. Welcome to Chapter 84, Allergy and Immune. I believe I have all of the weird little tech things squared away, so without further ado, let's get into our show. And let's get into, okay, I have most of the tech things squared away. Come on. There we go. Yay. Chapter 84, Allergic, Immune, and Autoimmune Disorders. What is an allergy? Okay. An allergy is an immune response. That is your body reacting to a foreign invader, if you will. An allergy is a hypersensitivity disorder of the immune system. So your body is reacting to something that would normally be innocuous. An autoimmune disorder, the body fails to recognize its own tissues and treats them as if they were an invader and begins to attack and destroy them. What do we get for diagnostics? We got lab tests, CBC, white blood cell count with differential, and eosinophils. You get eosinophil smears. Not caffeinated enough yet today, apparently. So blood levels of immunoglobulins and the ESR, which is the erythrocyte sedimentation rate. When your ESR is increased, it indicates inflammation. And as you may recall, I have a little bit of a fixation for inflammation because it plays such a big part in all of the things that we treat. Skin tests, epicutaneous or intradermal. So epicutaneous, that would be the allergy scratch tests. And the intradermal, like the tuberculosis test, the TB test that you take prior to going out to clinicals. These are gauging immune responses to these, whatever the allergen happens to be. As you will learn in Nursing 204, the intradermal injection, probably one of the hardest injections to master, because you're not aiming for a layer of skin, or I mean, you are aiming for a layer of skin. You're not aiming for a muscle or a layer of fat. You're actually slipping the tip of that needle in between two layers of skin. Allergies. If you've got them, you probably hate them. We have immunogens. These are antigens that can cause an immune response. And allergens, antigens that cause a tissue reaction. You can get allergens into your body via inhalation, say breathing in pollen, ingestion, eating something that you're allergic to, injection. Now that can be an insect bite, a bee sting, or us as nurses giving a medication via injection that the patient is allergic to, or direct contact. Think poison ivy or poison oak. Poison oak bee? Yeah, those. Now there is a difference between an allergy, an intolerance, a side effect, and an effect of a medication. An allergic response is an immune response. Now, a patient may receive a medication that they have an intolerance to, say morphine. In the majority of patients, morphine does not cause an allergic response. Some patients are allergic. Some have an intolerance where a small amount of morphine has an outsized effect on the patient. Side effects of morphine, well, sedation, respiratory depression, and the effects, the pain relief and the euphoria. We give morphine for pain relief. Some take morphine for the euphoric effect. But the thing to remember is an allergic response is an immune response. That is an antigen antibody reaction. An intolerance or a side effect may be intolerable, and an adverse reaction may be an intolerable effect of the medication or side effect of the medication. But an allergic response is the allergen antibody response or the antigen antibody response. Food allergies. Food allergy or a food sensitivity. The immune system reacts to an otherwise harmless substance, say lactose intolerance. Well, lactose intolerance and a dairy allergy are different. Lactose intolerance comes up when a patient is unable to digest lactose, unable to process lactose, whereas a milk allergy would be an allergic response to the milk itself. Something to note, allergy to dairy products like cow's milk. You may have a cross sensitivity to beef, which makes sense. And in some cases, I do not fully understand the pathophysiology. That allergy may take the form of a migraine headache. So drug allergies. A true drug allergy results from the antigen-antibody response we've talked about before. An adverse drug reaction, that's a noxious or unintended side effect of a medication. One has a serum sickness or serum reaction. The body mounts a reaction on the medication that has been administered, or on the serum that is containing that medication. Allergies with a skin response. Urticaria, also known as hives, reddened areas, itching, burning, hive wheals, or urticaria. Eczema, atopic dermatitis, little blisters. Many things can cause this, including heat, depending on the patient, or contact with irritating substances. Contact dermatitis. Well, okay, contact. You have inflammation of the skin due to contact with an agent, be it an allergen or an irritating substance. Respiratory response. This is where we start getting into fairly scary territory. Allergic asthma. The patient, let's just say, takes a face full of pollen, which causes the bronchi to spasm. When the bronchi spasms, you begin to lose the airway. And as you may recall, it's all about the ABCs. If you don't have A, B and C don't matter. Bronchial asthma, this is a recurrent condition. Can be brought on by many things, including exercise and stress. And then everyone's favorite, allergic rhinitis or hay fever. Your body is responding to pollen in the air as if it were a threat to your very existence. And if you're like me, and you have a beak this size, this allergic rhinitis can be quite unpleasant for the couple of weeks that the pollen is really flying. So multi-system responses. Now, again, we're moving into scarier territory. So let's take a bee sting. Starts with a localized reaction, but as that reaction continues, the immune system begins triggering GI and respiratory symptoms. This is where we start to worry about the reaction getting out of hand. Oop. Sorry, I tapped one too many buttons there. I'm still dealing with the technology. You know me and computers. So by the system, let's look at some reactions here. Skin, erythema, pallor, cyanosis, elevated temperature, rash, pruritus, and urticaria. Respiratory, rhinitis, runny nose, sneezing, stridor. That's where we start to get a little worried, right? Oropharyngeal edema. So you have swelling in the oropharynx. Again, potential for compromising the airway. Compromising A, B, and C don't matter. Cough, dyspnea, wheezing. Right, wheezing. You're hearing that as the bronchi begin to become inflamed. GI symptoms: NVD, nausea, vomiting, diarrhea. If you've got N and V, D is somewhere around there. Altered peristalsis, hence the diarrhea. The pain and cramping. Cardiovascular, tachycardia, hypotension, syncope, and shock. Recall from first term, what is shock? I'll let you think about that for a second. You can answer me, and then I'm going to tell you that shock is a precipitous drop in blood pressure, which could be brought on by a number of things. Shock is shock is shock. It is the drop in blood pressure. The cause of the shock may be hypovolemia, could be anaphylaxis, could be neurogenic, cardiogenic. It's a drop in blood pressure. Central nervous system, peripheral nervous system, anxiety, confusion, seizures, altered behaviors. And finally, in the ears, with the buildup of fluid and the inflammation, bulging tympanic membrane. Number one treatment, best treatment for allergies: avoid the triggers. Immunotherapy, minute doses to desensitize the immune system. These would be the allergy shots. Medication therapy in your book, 84-1, you've got antihistamines, though not for perennial allergies, right? These would be the H1 blockers. Why would you not want to use antihistamines for perennial allergies? Well, first think of what perennial allergies are, and go ahead and drop a comment as to why we wouldn't necessarily want to use antihistamines, especially first generation antihistamines, for perennial allergies. We have bronchodilators. Open the airway, because if you don't have A, B, and C don't matter. Corticosteroids to reduce inflammation. And leukotriene antagonists. Leukotrienes are incredible inflammation triggers, and if you can block the leukotrienes, you can block much of the inflammation. Here's our friend anaphylaxis. Okay, not our friend anaphylaxis. Severe hypersensitivity reaction can cause vascular collapse, can lead to shock, right? Allergies on steroids that can kill you. Not just make you wish you were dead, but actually kill you. This leads to hypotension, which can cause end organ damage, loss of airway. Anaphylaxis is nothing to fool around with. Any allergen can cause anaphylaxis. Could be something as simple as a peanut or a latex balloon or coconut. Any of these allergens can trigger an immune response in different patients that is so severe that it is life-threatening. So for nursing considerations, ABCs. Now here, it's sort of airway, breathing, circulation, okay? Starts with administer the medications. Get the airways open. Breathing, and then circulation. So administering medications, the latest and greatest is epinephrine first, to begin to counteract the hypotension and the airway constriction so that the patient can breathe and also support their blood pressure. Number one treatment for anaphylaxis. First step, remove the trigger, if at all possible. Removing the trigger, if the patient is allergic to latex and you have just placed a latex catheter, might be a good idea to get that catheter out. If you have just administered a medication, removing that trigger may be a little more difficult. Once you have given the medication, you cannot give it back, and that is why it is so important to not only know what your patient's allergic to, but know what the cross sensitivities might be. Epinephrine. Good old epinephrine. When it's produced in the body, epinephrine, norepinephrine, we used to call it, and still do call it, adrenaline. This has effect on various tissues, including causing tachycardia or increased heart rate, and vasoconstriction to bring up the blood pressure. This is your fight or flight hormone. It also works to open up bronchial smooth muscle so that you can pass air more readily. This is so you can either run away from the bear or have sufficient oxygen and blood flow to kill the bear and eat it yourself. Giving antihistamines. So once we have got the airways open back up, we still have an allergic reaction going on. We have a histamine response, so we give the antihistamines. First thing though, always ABCs. Administer meds, get the airway open, ensure breathing and circulation. And if the antihistamines are on board first, you may not have to administer epinephrine. Oh, yay. So immune disorders, infectious diseases. It's sort of right on the nose for the situation we're in right now with SARS-CoV-2 causing the COVID-19 disease. Overpowers the immune system. Immunosuppressed patients. The immune system weakened by could be several causes. Let's just back up here for a second. So stress will do it. Poor nutrition. If you are already or have already been ill, fighting off a disease, the immune system can be taxed. Medications can do this. Medications can suppress the immune system. Cancers. And of course, let's not forget HIV. Overproduction of gamma globulins in malignant and or chronic disease can attack normal body tissues and cause dysfunction. Anaphylaxis, we have an overreaction of the immune system. That is an immune disorder. And rejection to organ transplants. And recall that organ and tissue transplants, the patient in all but really one of those transplants, the patient will have to be on drugs for the rest of their life that suppress the immune system so that hopefully they do not reject the organ. The exception to that rule would be blood transfusions, which blood transfusions are a tissue transplant. Autoimmune disorders. So the body produces antibodies against its own cells, begins to attack its own tissues. Potential causes for autoimmune disorders: genetics. It can be as simple as the immune system was triggered at just the right moment due to, a physical, chemical, or biological agent. Abnormal immune cells. Recall, where are the immune cells produced? Where are white blood cells produced? Had that last week. So table 84.1, review that for relation of autoimmune disorders or autoimmunity to a number of different disorders. Let's look at types. So organ specific, there you have the rejection. Patient has had a kidney transplant and is not responding to the anti-rejection drugs, and the body rejects the transplanted organ. To systemic lupus erythematosus, SLE, or rheumatoid arthritis. But wait, doesn't RA just attack joints? Though it does have a tendency to attack joints, yes, but it is non-organ specific. It will attack the cartilage and joints anywhere it feels like it. So autoimmune disorders can have flares and then go into remission where things feels fairly normal. Those flares can be in varying intensities depending on factors such as, again, stress and medication response. Now here would be treatments for autoimmune disorders. They are difficult to treat successfully. You are treating the symptoms and treat it as the symptoms occur. Suppressing the antigen-antibody response, or the effects of the antigen-antibody response. Mild analgesics, generally not heavy-duty opiates, because the patient still needs to be able to function. corticosteroids to reduce inflammation, radiation and chemotherapy to suppress the immune system and to impact bone marrow, and then a class called DMARDs, disease-modifying anti-rheumatic drugs. These fall under chemo and biotherapies. And that, I just enjoy this picture. I don't know why. That is that. Fairly short chapter. We will be testing on that. I believe it is week 5. I'll have to look at the sheet again. Any questions, of course, email me. Drop a question in the comments. As starting next week, I will be working from home as we continue with our COVID-19 response. So I will be there and available in normal hours. Have a great weekend and enjoy.